Good afternoon and welcome to the National Academy for State Health Policy's webinar today, Value-Based Alternative Payment Methodologies for Federally Qualified Health Centers, Lessons from Colorado and Minnesota. I am Rachel Yelowich, a Project Director here at NASHP, and I'll be moderating today's webinar. So before we get started, just wanted to start with a few housekeeping items. First and foremost, your phone lines, if you're listening over the phone, will be on mute for the duration of today's webinar. Additionally, if you would like to ask a question or provide a comment to myself or any of the speakers, you can do that through the chat box, which is located in the lower left-hand corner of your screen. But please do be aware that the chat box may not be visible to you if you're viewing this live in full screen mode. We do encourage you to ask questions or provide comments about how the information being presented today is relevant to you and your state or organization. We would love to hear from you. And then lastly, at the end of the webinar, you'll be redirected to an evaluation of today's webinar through SurveyMonkey. If you are able to complete that evaluation, we would greatly appreciate it. Your feedback does guide our work and helps us to make webinars better over time. So as we get started today, I'll start by giving you an overview of NASHP's work with states on value-based purchasing for federally qualified health centers. And then you'll hear from Shane Mofford, Director of Rates and Payment Reform at the Colorado Department of Healthcare Policy and Financing. And then lastly, you'll hear from Deanna Mills, Director of the Federally Qualified Health Center Urban Health Network, about their experiences with developing and implementing value-based purchasing models in FQHCs. To begin, I wanted to talk to you a little bit about NASHP's work in this area. So we began planning for and launching the Value-Based Payment Reform Academy in early 2016 through a cooperative agreement that NASHP holds with the Health Resources and Services Administration. The goal of this work at our organization was to support states to develop and or implement value-based alternative payment methodologies for FQHCs within state Medicaid programs. We developed a request for proposals, and ultimately 6 states were selected to participate in the academy, and they received 15 months of technical assistance from NASHP staff, as well as other state, federal, and national experts on the topic. So to get started, NASHP here has a long history of supporting states interested in taking on value-based purchasing. As many states have been working on redesigning their Medicaid programs and how care is delivered, it's become clear to them that in order for practices to be successful in carrying out these advanced delivery system models like patient-centered medical homes or entering into accountable care arrangements, it's often necessary for them to provide additional services that, particularly for FQHCs, may not be billable under volume-based payment models, as well as employ a larger staff to take on team-based care models, as well as to account for increased need and capacity for health information technology and data analytics. And they really do, practices do need to enter into payment models, particularly in primary care, with greater flexibility than afforded in the fee-for-service world in order to support these delivery models. And so why should states think about including federally qualified health centers in their value-based purchasing efforts? Well, at the crux of it, FQHCs are a major Medicaid provider in a whole lot of states across the country. And so if states are thinking about how they can really transform and redesign their Medicaid programs to achieve the triple aim and improve care for beneficiaries, it's important to think about how FQHCs fit into that plan. And on the other hand, why would federally qualified health centers want to work towards value-based purchasing? It goes back to what I discussed on the previous slide. Many federally qualified health centers are already providing comprehensive coordinated care through models such as the patient-centered medical home model, and value-based purchasing or models that move towards value are potentially there and to help them better support those care delivery models that they're already, many of them are already practicing. And despite that FQHCs may need to take on some upfront costs depending on their capacity, particularly around health IT and data analytics, moving towards these value-based purchasing models may be attractive to them because they are looking for ways to better manage their patient population, and IT and data analytics is one of those ways. Additionally, we found that federally qualified health centers working on value-based purchasing with Medicaid programs in a fee-for-service environment also gives them some experience and helps them in negotiating more value-based contracts with managed care plans if there's managed care in the state. So it's important to note that federally qualified health centers are not paid like other Medicaid providers. The Medicare, Medicaid, and SHIP Benefits Improvement Act of 2000, or commonly referred to as BIPA 2000, requires that federally qualified health centers be reimbursed through the prospective payment system, which is essentially an encounter-based payment system or an alternative payment methodology, as long as individual FQHCs agree to be reimbursed through that APM and each clinic's total payments are equivalent or higher to what they would have received through the prospective payment system. So in working with states, it's clear that there is an opportunity for Medicaid programs to work with stakeholders in their state, including primary care associations and federally qualified health centers themselves, to develop and then ultimately implement account APMs that move towards value. So this is a categorical structure that the Healthcare Payment Learning and Action Network has come up with. I'm sure many of you are familiar with it. It categorizes value-based payment models from Category 1, which you can see has no link to quality or value. It's fee-for-service, all the way up to Category 4, which is a population-based payment in which practices or groups of practices are entering into arrangements where they have to manage the comprehensive care for their entire attributable population. And so I just wanted to include this in the slide deck so you all have a frame of reference on where we're coming from on the next slide. So now there's definitely a history of states including FQHCs in Medicaid, patient-centered medical home demonstrations, and pay-for-performance initiatives, and so those really fall into Category 2 on the previous slide, where it's fee-for-service and there's also some link to quality and value. So in a patient-centered medical home model, perhaps receiving fee-for-service and or PPS and a per member per month payment for care coordination, or being eligible for a pay-for-performance or pay-for-reporting supplemental payment. So because of that, right now, NASHP is really working on tracking state Medicaid programs that are designing value-based purchasing models, either specific to FQHCs or FQHC networks, or including FQHCs or groups of FQHCs as eligible providers in Medicaid, shared savings, and population-based payment models, so Category 3 and Category 4 payment models in the Healthcare Payment Learning and Access Networks structure. And so among the active initiatives, which you can see in green on the map on your screen, to give you an example of what's going on in some of these states. So in Minnesota and Maine, for example, groups of FQHCs have joined together to participate as a Medicaid ACO and take on enter into shared savings arrangement with the Medicaid agency. And you'll hear from one of those FQHC groups later in today's presentation based in Minnesota. And then you'll see on the West Coast in Washington and Oregon, for example, they have developed a FQHC-specific alternative payment model that at a high level prospectively pays participating health centers a per member per month payment rate for their attributed Medicaid population, and that per member per month rate is, again, at a high level, this is not that simple, but derived from each FQHC's prospective payment system rate and historical utilization. And so you'll note that there are the 6 states that we worked with in the Value-Based Payment Reform Academy: Nevada, Colorado, Oklahoma, Michigan, D.C., the District of Columbia, and Hawaii. And many of our states are very interested in developing a per member per month model similar to the one in Oregon and Washington, largely because of the potential flexibility that it affords it. The opportunity to decouple face-to-face visits with payment is very attractive to some states and the FQHCs in those states because it's more flexible payment for non-billable services like care coordination that FQHCs are already providing there. And you'll hear more from Colorado, who is in our academy, about their progress today. So after working with the Academy states for 15 months, I want to share a few lessons learned for states to consider as they get started and go down this path of developing value-based payment models for their FQHCs. So first and foremost, it's incredibly clear from the states we work with that it is important to identify a vision and shared goals for how care should be delivered, and then after that, determine what needs to change about payment to best support providers to achieve that vision. And relatedly, it's critical to foster trust and transparency among state agencies and organizations involved in model development, and specifically involved in defining that vision and shared goals. So all 6 of our state teams included senior Medicaid leadership, senior primary care association leadership, and CEOs and CFOs from a number of federally qualified health centers on their teams in order to, again, identify that shared vision and goals for how care should be delivered, and then what needs to be changed about payment. And interestingly, 2 of our states included Department of Health leadership on those teams for their expertise in workforce, focus on chronic disease, and social determinants of health. So another lesson learned is also, of course, to consider state agency bandwidth and opportunities to align FQHC payment reform with broader Medicaid initiatives which may help, and that alignment may help with bandwidth issues at the state agency. And you'll hear from Colorado a little bit about how they are trying to align FQHC payment reform with other primary care payment reforms in the state. It's also important for state Medicaid agencies to determine the necessary departments that should participate in the development of this model. Of course, rate setting, potentially managed care if you are a managed care state, provider and program capacity departments, IT, and of course, quality improvement. And states should work with their primary care associations to assess FQHC readiness. Primary care associations are an important partner, we've found, from working with our states, because they know the capacity of the federally qualified health centers and are able to work with them and support them to develop the capacity they need to ultimately take on more payment models that move more towards value. And also important to remember that because alternative payment methodologies are opt-in, not all health centers need to be ready at launch. So some states might want to consider developing a payment model that's a pilot. And last but not least, of course, APM development takes time, and so it's important to have staff that are engaged in this work, so that way, as things change in the state, there's tenure and you can help with this. I'll just share that NASHP has some forthcoming resources that will be released on our website and in our weekly e-newsletter that you may be interested in as you're thinking about FQHC payment reform. So we are working on a series of blogs that share lessons learned from the Academy, as well as what's going on in other states around the country. And then also, if you want more lessons learned from our states and to review a roadmap for how to develop a FQHC payment model, including key considerations and lessons learned that is based upon our state's experience in the Academy. Stay tuned for a toolkit that will again be released on NASHP's website and in our weekly e-newsletter anticipated in October 2017. So thank you, and my email address is on the screen in front of you, and feel free to reach out to me with any questions about the Academy or for more information on value-based purchasing and in FQHCs generally. So with that, I will turn it over to our first speaker today, which is Shane Mofford. And Shane has served as the Director of Race and Payment Reform for the Department of Healthcare Policy and Financing in Colorado for about 2 years now, and he's been with the department for 7 years in total. He has been working in healthcare for over a decade in a variety of roles, and he has led or has closely been involved with many of Colorado's healthcare reforms, including several initiatives to expand integrated care, managed care reforms, and behavioral health reforms. And he's also been working closely with us here at NASHP and the rest of his Colorado team on developing a FQHC alternative payment model in the state. And with that, I'm happy to turn it over to Shane.
Great. Thank you very much for the introduction. I don't know if anyone can see the slide deck at this point. If you can't, just assume that it was incredible. We'll run with that assumption for now. I'm going to, given that you can't see this and I can't see your questions currently, I anticipate that we'll post these online at a later point, and I do have contact information at the end, so feel free to reach out to me if you have questions from the presentation. So our mission, I think it's always important to start with that, improving healthcare access and outcomes for the people we serve while demonstrating sound stewardship of financial resources. I actually want to start by providing a little bit of context. Payment reform happens within a context, and unless you operate from the perspective, as was pointed out, there's a lot of things going on, and creating alignment is the path through it. And the context in each state is going to be different, and you need to pay homage to that. So I'll walk through the lay of the land. Actually, I'll go pretty quickly through that. At the federal level, there's obviously a lot happening. And within Colorado, there's a lot happening. And then the actual work and what we're doing with FQHC reforms I'll cover. So nationally, as you all know, and you saw on earlier slides, there's a push for value-based purchasing. There's a framework that's been put out from the Learning Action Network. I like to summarize that as more quality and more accountability through financial risk is more advanced. That flexibility coupled with accountability for outcomes is a good thing. And we in Colorado have made a commitment to advance value-based purchasing under that framework. Implementation of MACRA is a huge impact on primary care, and we think that both for FQHCs and non-FQHCs, it's important to maintain alignment. CPC Plus, the Comprehensive Primary Care Plus initiative, is another opportunity for primary care to participate in practice transformation and payment reform, and Colorado is selected and is participating in that program as well. And then lastly, Colorado is participating in the state innovation model demonstration. We received a large federal investment to promote integrated care and public health policy advancement at the state level. And so specific to Colorado, we have a lot going on. In Colorado, we have what's called the Accountable Care Collaborative. We are predominantly a fee-for-service state, but our service delivery is managed by accountable care organizations. As I've already mentioned, we also participate in CPC Plus, SIM. We've engaged in pretty major behavioral health reforms to promote integrated care, managed care reforms to introduce accountability for quality, hospital reforms we're currently engaged in, long-term services and supports and PACE reforms, and then of course primary care reforms. And back to that point of alignment, you have to recognize that all of these things impact one another in different ways. So for example, introducing additional accountability for primary care to avoid ER utilization. If the hospital up the street is marketing for no emergency room waits, that it can be difficult. So implementing reforms that are mutually reinforcing is important. I think you're all missing a really pretty slide right now, but we have a lot of...
Sorry to interrupt. This is Rachel.
Oh, yeah.
I just want to let you know that most people are back on the web and can see the slides.
Okay, perfect. Are you able to advance them?
We are advancing them for you, but if you want to say next slide, that would be great.
Perfect. I will keep up separately. Thank you. Okay, so in Colorado, what you see on the slide is a distribution of our expenditure here on slide 6. And you'll see that FQHC and RHC reimbursement is towards the top. It represents a relatively small percentage of the total expenditure. But it's important to invest in FQHCs and think strategically through payment reform, because what happens in the FQHC has the ability to impact all of the additional cost areas. Hospitals, the giant one in the center, that's probably similar in every state. FQHCs have an opportunity, when provided with the right flexibility and the right financial incentives, to really get upstream of that utilization and have a strong impact on the cost curve while improving quality for and client outcomes. On the next slide, slide 7, you can see where we have active payment reform efforts underway. Again, we have behavioral health, managed care, FQHCs, primary care, hospital reforms, and then, of course, our Accountable Care Collaborative. So why FQHC reform? So on slide 8, primary care investments can reduce downstream costs. So this is what I was just talking about. If we invest in upstream interventions and prevention and provide the flexibility to really meet the client where they are and address their needs regardless of how medicalized their perceived need is, you can get upstream of the hospital utilization and save a significant amount of money. In Colorado, approximately 40% of clients that are attributed to primary care practices through our Accountable Care Collaborative, 40% of the clients utilize FQHCs. So that means that FQHC reforms are actually a critical piece of ensuring that your entire delivery system is moving towards higher quality and more efficient outcomes for clients. But additionally, just to look at the FQHC reimbursement model in isolation, the PPS model is, and I've characterized it as antiquated, and there are some strong perverse financial incentives within the model. It's the pay-for-volume problem that we experience in fee-for-service in general. There's an incentive to drive as many visits over prior years as possible to maximize revenue, rather than to provide as high of quality services and reduce total cost of care. And the regulatory framework, fortunately, allows us the option of implementing alternative payment models and to deviate from the PPS framework in a way that we can get those results. So what exactly are we doing? On slide 9, you'll see that, as was already mentioned, Colorado is participating in a technical assistance grant. That has been just absolutely crucial to us making progress, being able to tap into expertise nationally and to have a driving force for collaboration, ensuring that communication is happening, has been highly valuable. And we are attempting to implement 2 models. They are both on track for implementation for 7/1 of 2018. The first model is to implement a limited risk capitation with a tie to quality. That's essentially the PMPM model that's been talked about. And we've also introduced, across all of primary care, a quality performance monitoring program, and it applies to the PMPM model as well. So essentially, the better quality as defined through that program, the higher the reimbursement through the PMPM model. The second model is essentially maintenance of status quo, but with the introduction of the quality incentives. In Colorado, we have historically paid a full cost-based rate rather than just the PPS rate. And that means that there's opportunity. So there's a gap between the federal minimum and what Colorado has historically paid. we're going to put a portion of that gap at risk and attach it to quality outcomes. So practices that don't participate in the PMPM model will be participating in the second model, where we attach their encounter rate to a quality outcome. So on the next slide, slide 10, I've outlined 4 areas that have some pretty critical lessons learned from my perspective. And then after we get through these, we can take a moment to ask and answer questions. So first and foremost, stakeholder engagement. That's mission critical, and we'll talk about that in a second. The second area is program design. That includes 2 pieces, so cleanup of current state and building future state. We'll talk about that in a second as well. Authority, and lastly, the operational strategy. The stakeholder engagement, that's almost a buzzword in some cases. Stakeholder engagement has been the only reason that we've been able to make progress. And I think that rather than calling it stakeholder engagement, we need to talk about it in terms of partnership. Priority number 1. So FQHC alternative payment methodologies require FQHC consent to implement. So if you do not have a partnership where you can get to a mutually agreed upon payment methodology, you literally cannot implement it under federal regulations. Additionally, building and operationalizing new payment models that are sustainable and drive real change requires boots on the ground insight. While at the state level, we do have the ability to do research and to learn from the lessons of other states. Each community operates within its own context, and we don't have direct line of sight to that context. So partnership is the mechanism by which you gain insight into how you build business, or how you pay for business processes that get you the best results. And absent partnership, you're not going to have that level of insight. And then lastly, reform. Those of you that are engaged in it I fully imagine that the statement will resonate. Reform is hard and resource intensive. And state programs are typically not heavily resourced. Certainly we're not in Colorado. I believe our total administrative budget is 3% of our total spend. Not exactly a typical payer ratio. And just to be blunt, you're going to need to tap into the resources of the professional association. Having an entity that can coordinate communication to help providers work through the operational detail. Our reform efforts would not have been successful absent the full investment of the Primary Care Association. So partnership, that's the first step and the most critical. Program design. So resource constraints are real and always have been. This goes back to the point of alignment. So if you're working on reforms across a variety of different areas, alignment isn't just something that makes the resource and the administrative burden on providers a little bit less. It's also something that's critically important internally. For example, we're implementing FQHC reforms and other primary care reforms. We're trying to leverage system designs that are similar enough to where we can essentially kill 2 birds with 1 stone. So alignment to address resource constraints is pretty important. When you look at your program and your FQHC payment models that you currently have in place, and you're thinking about reform, it was our experience that we identified, just by virtue of investing a lot of focus into what is happening currently, you find a lot of things that you have to fix before you can even progress with payment reform. Anecdotally, I've heard that that there are a lot of states that do not have a very concrete change in scope process. Having appropriate change in scope processes in place can be pretty critical to prior to moving to a PMPM model. But if you didn't have something concrete in place or something that wasn't utilized appropriately historically, you'll have to invest time in correcting those processes. So before engaging in reform, make sure that you have enough room to focus on cleaning up current state as well. Also look to other examples. A lot of work has already been done. One of our big lessons learned is that there is a tremendous amount of nuance in reform design, but a lot of very bright minds across the country have solved a lot of the hard problems. Look for other examples. Don't try and recreate the wheel. Next, authority. This is probably the only time I will ever say this about authority for Medicaid, but the authority piece on moving to a PMPM model is not too bad. It actually doesn't require a waiver to implement an APM, depending on how you structure it. We can actually, what we're doing, implement through a state plan amendment. So long as you're engaging with CMS early and often, we're not anticipating any major authority concerns, but our lesson learned and our recommendation is to work early and often with CMS. And then the last area for considerations is the operational strategy. Again, reform is hard. I would strongly recommend that you give yourself enough time. As I said before, things are going to come up. Just getting a level of consensus with the provider community on the parameters of the model is going to take time. I think for us, we'll have a total investment of a little over 2 years in the development leading up to implementation, and every second of it was necessary. Planning and project planning that's detailed will also be helpful, and to map out all of the considerations prior to engaging in the work is going to be really important. And another key lesson learned for us, I think, is that while external engagement is important, internal engagement is just as critical. When we're talking about payment methodologies and how they're implemented, it's really, well, at least in Colorado, based off of how we're organizationally structured, it requires effort and input from people across the entire department, everyone from systems, accounting, data for the quality measures, our quality staff. And to make these types of reforms successful, it takes in our case, a department-wide commitment to making this happen. So having an internal engagement strategy that parallels the external engagement strategy is also very, very important. So that's essentially the rundown of some of the major highlights, what we're doing, why we're doing it, and where we're going next. So if there's any questions, I guess, Rachel, could you read them for me? Would that be possible?
Absolutely. So what we're going to do is we're going to we're going to have Deanna, our final presenter, present, and then I'll facilitate the Q&A and I'll read them aloud, Shane.
Perfect. Thank you very much.
Okay, great. So thank you so much to Shane for his really excellent presentation. It's been a real pleasure to work with him and the rest of the Colorado team as they work on developing this APM model. And so with that, I'll turn it over to Deanna Mills. She is the Director of the Federally Qualified Health Center's Urban Health Network, or FUN, as of November 15. And FUN is participating as a Medicaid ACO in Minnesota's Integrated Health Partnerships, or Accountable Care Organization Initiative. Prior to this role, she served as the CEO of the Community University Health Care Center at the University of Minnesota for 10 years, and she's held a number of other high-level positions with managed care plans and with other FQHCs. She's also worked as a senior consultant for a healthcare consulting company in Minneapolis, where she's based. She holds a master's degree in public health from the University of Minnesota. And with that, I'll turn it over to Deanna.
Well, thank you very much. And Shane, it's hard to step up and watch you just on the spot do your presentation without your seeing your slides. So I appreciate that. Yeah, can you go to the next slide? So thank you for listening to me today. Before I start on my presentation, I just want to tell you what is FUN. And you notice there's an H in there, not F-U-N. So we are the Federally Qualified Health Center Urban Health Network. And what that means is we're a collaborative partnership of 10 Minneapolis-St. Paul FQHCs. We've been at this since 2010. So we were, although that I love to see the map getting filled in, the nation's first FQHC-only safety net Medicaid accountable care organization. Next slide. So our member clinics serve about 110,000 patients in the Twin Cities area. As most FQHCs, our clientele, our patients are very diverse. Many need to be served in a language other than English. 95% are under the 200% federal poverty guidelines. Half of the patients are Medicaid, and you can see the other uninsured commercial and Medicare. We have 40 unique service sites, and like many FQHCs, all of them provide medical care, and then an assortment of dental, mental health, substance abuse, vision enabling, and also a variety of special programming, homeless, public housing, schools, and you can read the rest of them. But we're typical of many FQHCs across the country. Next slide. So the topics I was asked to cover today is funds participation in the Minnesota Department of Human Services Medicaid program, which they call the Integrated Health Program or the IHP program. And so why did we do that? I'm going to talk about why we did it, the results we've achieved to date, and the resources that FQHCs need to succeed. Now, I know that many of you are probably with Medicaid department, so I am not that. I can't represent their position. I'm just representing the partners or the clinics that are in the FUN network. Next slide. So the overview is we're working with Minnesota Department of Human Services with their Medicaid ACO program. Now, the goal of that program is pretty familiar to most people right now, which is to achieve the triple aim, which we all know. But we added a +1, which is to increase primary care access for vulnerable populations. We basically had the philosophical premise that total cost of care and clinical outcomes can be improved by increasing access to primary care. Next slide. I just want to let you know that there is or was some Minnesota health reform legislation in 2010 that allowed this Medicaid demonstration to occur. And there's a reference at the end of the presentation that you can click on and find that actual legislation. And why we wanted to choose to do this was, healthcare reform was here. And we viewed this as an opportunity to leverage resources, foster collaboration among the members, and to learn together because we knew healthcare reform was before us. We also saw it as a threat, that it was a quickly reforming healthcare environment, and we needed to figure out how to operate in this new environment. Many of the clinics said maybe they should join larger healthcare systems to gain access to resources because as many FQHCs, we don't have a lot of resources. Or did we think we could take a leap of faith to transform our clinical practices? Well, FQHC missions, are really to serve underserved patients, and they're governed by patients of the clinic primarily. And so it's natural for us to want to transform our clinical practices, take a leap of faith, and move forward with these things so we could have the control of what we do in our community. And I want to say one more thing. This Medicaid ACO was not developed for FQHC. It was developed for any Medicaid provider in the state of Minnesota. So this isn't a specific FQHC project. Next slide. So to continue, we knew that we had to do significant clinical transformation in order to have our payment base completely upended and be paid in a totally different way, similar to what Shane was talking about with the APM models. But we also believe that, we are the model for this population. For years and years, as was said earlier, there's FQHCs serve a lot of Medicaid and underserved patients, and really we bring in also the social determinants of health. So we believed that We needed to get the work done to transform, and we believed that we were the model to show how this could be done. Next slide. Next slide, please. Thank you. Back one. The pictures. Okay. So several people have said already that this healthcare reform stuff is hard, and we have often used this picture. You know, we used to play checkers all the time, but now we have to do this three-dimensional chess activity, which it's always changing and always reforming. So what happens today, you know, is going to be evolving in the marketplace in the future, and frankly, very quickly. Next slide. So recognizing what we needed to do, we said we need to transform our clinical practice, and that just means people, process, and technology. Next slide. Because it is a pretty significant change to the way the clinics get paid, you have to infuse change management techniques into your practice because it is a culture change. So what we decided to do is take steps. First of all of our member clinics became healthcare home certified. And what that really did was provide the policies, procedures, and processes to learn how to do care coordination. We also knew that we had to bring in e-health technologies and data analytics so that we could do predictive modeling. We had to do identification and stratification for the patients who had gaps in their care and led to higher costs. And we knew that we didn't have all the information of all the care that our patient got, so we needed to get connected to an e-health exchange. And then after we got the policies and procedures and we got the data analytics, then we had to say, well, now what are we going to do in terms of clinical interventions? And so we designed some standard medical protocols, some workflows and processes, and trained the workforce in order to move forward. An example of this would be, which is true of many Medicaid populations, to avoid, to reduce the number of avoidable ED visits. So we looked at all of our data analytics and said, what are people going to the emergency room for? We knew that kind of the low-hanging fruit was upper respiratory infections. So we developed some medical protocols around the upper respiratory infections. All the care coordinators were trained on those processes so that we could reduce the ED utilization. Next slide. So what's involved in clinical transformation is a lot. We, as FQHCs, have said we always do care coordination, and we have, but we did it in a different way than we have to do it going forward. So many of these terms right now are probably very familiar to most of you. Motivational interviewing, we had to train our staff on that. Lean process improvement, we had to learn how to change our processes around. We had to train all our staff on how do you use population health on data analytics. It's not something that a lot of people learn. And what is team-based care, where people are operating at the top of their license? What is pre-visit planning before the patient comes into the clinic? What are daily huddles that people have to do in order to manage the care as patients come through? And where are you referring patients? And more on our administrative side, we had to really understand the responsibility that we had for the care that was received outside of our four walls. And we really had to go into what is this gain risk sharing around TCOC and quality and patient satisfaction. They were all new things that we had to learn. Next page. So here are some of the results I'm going to talk to you about. So we started this in 2010 because that's when the legislation was passed, but the actual performance year didn't start until 2013. And we had approximately 24,000 attributed patients. By 2015, we had approximately 32,000. And that was due to the Medicaid expansion, Minnesota's Medicaid expansion state, and we moved from a 12-month to a 24-month attribution period. And just so you know, the number of attributed patients represents only about 55 of our Medicaid patients. There were a number of Medicaid patients who were not attributable based on their enrollment in Medicaid, and then there's certain churn that goes on as well. Next page. So here's annually, we have approximately $175 million of total cost of care for the a little over 30,000 people who are attributed to us. But we were really only responsible for $140 million of it. Now that's still a big number. There were a lot of things excluded from the Medicaid services, such as dental care, long-term care, durable goods, home health care, those sorts of things. But 100% of pharmacy, 99% of outpatient, professional, 97% of inpatient, and 43% of mental health and CD were included in that $140 million. Next page. So this is one of my favorite and one of my least favorite slides. Favorite because you can see at the top in 2013, we had a 3.1% decrease in the total cost of care, and 4.6% in 2014 and 5.9% in 2015. So we definitely were doing the work that needed to get done in order to reduce the total cost of care. In this scenario, as part of the IHP program, the savings accrued, which was a little over $17 million, the state actually retained 50% each year. So the other 50% is given to funds. And over those years, and that was pending also achieving some quality metrics, we got $8.661705 million. Now, this is the least favorite. That of that, because we were FQHCs, we had no capital to invest in this project. We didn't have the staff, we didn't have the data analytics, and frankly, we didn't have the business IQ. So we engaged an administrative partner that actually decided to go in full risk with us, and they took all the risk up front. And at the end of the day, if we saved money, we had to repay them their costs and some of their return on investment. So even though we saved the state about $8 million, and we got $8 million, a good share of it went to our administrative partner. These kind of programs are very expensive for FQHCs. Next page. Our quality and patient satisfaction, you could read they were dependent. If we saved money, we had to, our savings were dependent on 25% was withheld until we could prove that the quality outcomes were good. 50%, we had to have a relative improvement in some key clinical areas, and we had to show good patient satisfaction on certain areas as well. Next slide. Next slide, please. So I talked to you earlier about the ED utilization, and this is always the low-hanging fruit in these kind of programs, is to try to move patients from going to the ED for primary care-based services that can be seen in the clinic. So we were able to reduce ED department visits by 27% over 3 years. Next slide. Now, likewise, but not precisely the same, we also decreased inpatient admissions. And this was basically focusing on some chronic care conditions that our patients experienced that were kind of out of control, that we were hoping to get better control with them on some of their chronic conditions, such as diabetes. Next slide. So how did we achieve these results? This was a very highly competitive group of 10 clinics across the metro area. And we said we got to move from competitors to extreme collaborators. And that's really what we did. And then it was our staff, from the CEOs to the frontline care coordinators, who became collaborators in this project. Next slide. So our structure, we are a network of clinics. We are a 501c3. And so each one of the clinics, the FQHCs, have a place on the board of directors. And then we have a number of committees that are made up of people who work in those clinics, such as the 10 CFOs, the 10 medical directors, the quality people, the care coordinators. So it's very much part and parcel of the operations of each one of the clinics. Next slide. So the key things that we had to do in terms of action was to get actionable data in the hands of the primary care providers. So that meant that we had to have a robust data analytics system, and we had to have dedicated personnel to work with that those data analytics. And so this gave us, for the first time ever, a sightline to what healthcare services our patients were using outside of our office. Next slide. And as I saw in that, my most favorite and my least favorite slide is this is to implement this data analytics and this care coordination program is very expensive. Hiring the people, getting all the data analytics set up. So that's why we relied on Optum. And we were very fortunate to have them work with us. And over time, as we began to be smarter ourselves, we were able to change our relationship with Optum to just provide our data analytics, not necessarily all the personnel and other services they provided to us. Next page. So we really focused on we had about 32,000 patients, and you can't care coordinate all of those patients. So you need to do some very clear ID and stratification in order to reach the patients that you can most likely save money and increase the care outcomes. So we chose emergency department reduction for minor conditions, as mentioned before, asthma management, diabetes management, and certainly pain management, opioid Rx. So we developed standard clinical policy that all 10 clinics used, because we do know that patients go between clinics, and we reorganized some of the workflow regarding these 4 conditions. Next slide. So as I said, we have changed our relationship with Optum because we are building our own health information technology. We were able to, Minnesota's a SIM grant, and so we were able to, a SIM state. So some of the money that NVH and DHS in Minnesota got, they lended out to us as well as other people. And now we are building a data analytics infrastructure that will manage our value-based contract arrangements. So this will be a data warehouse that will receive real data feeds from each one of the FQHCs EMRs. We have 5 different EMRs in our 10 clinics. It will also bring in all the claims data currently that we get from our state human services, and in the future we certainly hope it will bring other pay claims data from other sources. And in the future we're trying to get all of the other e-health technology like the admit, discharge, and transfers from selected hospitals. We also will have a data analytics capacity, and we know that this is pricey, but we know that the future gain savings, we know we can save money, and that is partially how we believe that we can fund this project for the future. Next page. We were also extremely happy that in 2016 we were granted from the federal government a Health Center Controlled Networks grant, which provides the ongoing funding for staff. It's a 3-year grant, and I believe that if we achieve our goals, we might get renewed again for another 3 years. We're looking forward to that. But this certainly will help in sustainability. So we're building our data analytics warehouse, and we have our staff to run it and our clinics set up to continue in this value-based contracting world. Next page. So we all have our lessons learned. These are our lessons. Value-based contracting requires clinical practice transformation. And if I would have said that to myself back in 2012 when we started this, I wouldn't have known exactly what that meant. But 2020 back, it requires a significant clinical practice transformation. The upfront capital for technology is very expensive, And in our case, and for anybody else going in this kind of situation, risk partners that take most of the risk will also take most of the money. You have to invest in staff retraining. Most staff, when they come out of colleges and universities right now, are not trained in value-based contracting. Hopefully that is changing and as time goes on, but there's a lot of people who haven't benefited from those kind of things. So there's a lot of staff retraining that is important. And we believe that FQHCs are the model serving the Medicaid population, as I talked about before, and it is possible that you can reduce total cost of care and you can get improved outcomes. So thank you for listening to me. Next page. And there I am. If you want to contact me, here's my email. I'm not scary. Just contact me if you want. Matt Span at the Minnesota Department of Human Services is the manager of these integrated healthcare partnerships, and his contact information is there. And if you want to look up the statute that allowed this kind of ACO demonstration to happen, that is the link. So thank you for your time, and I'll take any questions. I can't see any questions, but I'm sure you'll help me out on that one. Thank you.
We most certainly will. Thank you very much, Deanna, for that excellent presentation. It's wonderful for you to be able to share all the great work that FUN has done in participating in a Medicaid ACO program. So we do have a number of questions in the queue, and so I'll read them aloud to our presenters, and I'll direct them to one or both of you. So the first question, Shane, about the Colorado model. So the capitated model that you discussed in your presentation, there's a question on whether or not that is based on your current encounter rate methodology, or whether the capitated model, the rate in the capitated model would be based on the health center's PPS rate.
That's a great question. We are using our APM methodology, so not the PPS. However, we are modifying what would have been the encounter rate by a quality adjustment factor based off of quality performance.
Great, thank you. And as a corollary to that, the second part of the question is, what would be the implication for health centers not meeting quality targets under the capitated model?
There's potentially two. The first is that there would be a reduction in reimbursement so long as we're above the PPS floor. That would be the consequence. The second is that it would, depending on, in particular, if it was something related to access, we'd likely seriously evaluate and work with the practice to ensure that it's the appropriate model for them to participate in.
That's really helpful, Shane. And can you clarify for folks on the phone, if an FQHC is participating in the capitated model, would they also be participating in that pay-for-performance model, or would that just be for health centers that maintain their encounter-based payment?
The pay-for-performance, where we essentially increase the underlying encounter rate, does apply to both programs.
Okay, great. So now we have a question for Deanna, and someone in the audience is hoping you can describe how the 12 or 24-month attribution period works.
Yes, I can. So the attribution is based on a series of algorithms. The first one is, I won't be able to remember all the steps off the top of my head, but I'll be able to remember the first three. So the first one is, in Minnesota, if you have a patient enrolled in a healthcare home, you are automatically attributed to that healthcare home entity. The second one is, it's all based on codes, CPT codes by primary care providers. So if there's an E&M code or an evaluation and management code, they're attributed to the clinic and the provider that they've seen. Sometimes patients, as we all know, move around to different clinics. So if they have E&M codes in various clinics, they will take the E&M codes that they had at the most at the clinic. And then sometimes they have equal. They've been to one clinic 6 times and they've been to another clinic 6 times. And so it would be the latest that they went to. So after that, it gets more complicated in terms of the algorithms, but the majority of the patients who are attributed based on those first few steps. There is a way to look at that. If you go to the Minnesota Department of Human Service resource, or even contact MapSpan, because all of this is online and you can see how patients are attributed. Does that answer the question, hopefully?
Yes, I think so. And also the slides for this webinar will be posted on NASHV's website within 1 week. When you navigate to www.nashv.org, there is part of our resources. You'll see there's an opportunity to click on webinars, and that's where you'll find the recording as well as the slide deck for this. And so you'll note that Deanna, for folks that are interested in also following up with Deanna or Matt Spahn at the state about the IHP program or funds experience, their contact information is there. And so another question for Colorado that's coming in is, Shane, has Colorado received approval from CMS for this APM?
We have not yet even submitted the SPA, but we've had multiple meetings with CMS, both at the regional and central level. We all are conceptually in agreement, but the devil's in the detail. However, we think that we'll have the support needed to execute prior to 7/1 of 18.
Great, thank you. And then another question for back to Deanna. So when taking into account additional staff and other expenses borne by FQHCs when you were in your network, when you were entering into the IHP model, what did you feel like there was a return on investment for all of those capacity building expenses that the FQHCs bore?
We haven't done an analysis that said each clinic put in this much change and this much staff and those sorts of things and returned this much money. We haven't done that. I know from when I ran one of the clinics in this demonstration, we did write a lot of grants to fund certain positions like care coordinators until we could get to the point where we could restructure staff duties and responsibilities, and until the culture changed so that staff were all working together. So there isn't necessarily special positions anymore because everybody is working on the value-based in the way that we need them to. Initially, our administrative service partner, Optum, provided 10 care coordinators that were assigned to each one of the clinics. And they were part of the learning process that we had. So they helped us implement the program, as well as taught us how to do the data analytics analysis, as well as helped us in a lot of the performance improvement initiatives that we had to put in place. So I would say that the investment that Optum put in and what we ended up paying them was certainly at the high price, but at the end of the day, we needed to transform, and they knew how to do it, and they knew how to help us. But now that we're there, we don't need that level of experience anymore. And we've been working with our Department of Human Services, and they have changed actually now to, this is the next version of the model that they're implementing. They are starting to pay upfront care coordination per member per month fees in the new models that they are implementing starting in 2018. So they heard basically from all of the IHPs operating in this program that you just can't put a big new care coordination and a bunch of new work on already overstressed clinics. You need to be able to provide for that up front. And so that was a success, I think, on behalf of the providers in the state of Minnesota, and a great response from the Minnesota Department of Human Services.
Thank you, Deanna. That's very interesting. So I know that you all are in a 3-year contract cycle. Will that change in 2018 apply to FUN as well?
Actually, no. We're in a 3-year contract for 2013 through 2015. We're in a second 3-year contract, 2016 through 2018. The model that fund is currently operating in will not continue for us in 2019. So we will have to move to one of the 2 models that DHS has now devised as part of their learnings and as part of probably CMS's encouragement. There's a population-based model that we would likely go into. The other is an upside-downside risk, which we're not too excited about. But we like the population-based management, population-based payment model. However, we don't get to share in the savings. So we are looking and very interested, frankly, in all of the APM models that are developing across the country now, because we may be able to incorporate some of those APM models into this model here in Minnesota. So I appreciate listening to all the of Shane and everybody else that I heard at your academy too. Very interesting.
Thank you, Deanna. That's very interesting. So another question for you is a listener wants to know if the Primary Care Association in Minnesota is involved at all in your transformation activities and or how have they been engaged in value-based payment reform in Minnesota, if you know.
I do. We work very closely with our Minnesota Primary Care Association. Although FUN is a separate 501c3, we do work very closely with them. There certainly are a number of public policies that come into play that we depend on the Primary Care Association to move our initiatives or our concerns forward. They have allocated staff to help in our FUN projects, especially the quality initiatives, because we share some common goals. We have some ongoing discussions with quarterly discussions on what are they doing, what are we doing, how can we work together on collaborative ventures. So we're very involved in our Primary Care Association. They actually were the ones that were the first group who said, you know, all of the FQHCs in the state, and there's 17, not just the 10 in the metro areas, brought to our attention that it's time to consider value-based contracting and clinical practice transformation way back in 2011. So they were really the impetus or the impetus to get us all thinking about what the opportunities and what we needed to do.
Great, that's excellent, and I think rings true through all of the lessons learned that you and Shane and I shared from the other states in the academy about how important partnership really is. So we have one question here that asks about how taking on downside risk through an APM model reconciles with the prospective payment system requirement that an APM must result in a payment of at least equivalent to the total payments through PPS. And Deanna, can you comment on that? I know you are right now, FUN is only taking on upside risk, but have you all talked about, how moving towards more advanced, risk-sharing contracts would work in an FQHC ACO?
I can comment on it a little bit. We are in a shared savings only upside risk, no downside risk at all. So the clinics continue to bill just like they've always billed with their PPS rates, and so there's nothing that changes in the clinic setting for that. As we move forward, I think that there's an opportunity to work with our Department of Human Services to develop similar payment methodologies that might use an APM with a shared savings model. But we're in the front end of those conversations right now, and at this point, we are not very interested in taking downside risk. We think there's other models that can reach the value-based contracting that we're very interested in pursuing at this point in time.
Shane, did you want to? I know that's not part of your model, but had you all talked about that at the state level? thought about developing your payment model, and did you want to comment at all?
Yeah, maybe two things about that. I agree it doesn't reconcile very well. If anything, the PPS serves as a floor for the amount of downside risk available. And you don't prospectively know whether or not the PPS produces, whether or not it's adequate to cover all of the costs. So there is genuinely the possibility of downside risk. I think to have it be meaningful, and you would actually have to pursue something like an 1115 waiver, and that's the type of action that might lose some of that partnership, to be just blunt about it.
Thank you. And so I do see that we have a number of unanswered questions, but because we are coming up on time and I do want to respect your schedules today, I'll move us towards wrapping up in the final minute. So I just wanted to remind you all that there are a few forthcoming NASHP resources, a blog series, as well as a toolkit, which we hope will serve as a roadmap for state policymakers and primary care associations alike as they work together across the country to partner and work on value-based purchasing for FQHCs. We hear from a lot of states that this is a very much a topic of interest, and so stay tuned to NASHP's website and subscribe to our weekly e-newsletter to stay alerted to those upcoming resources. And also my contact information is on this slide, so feel free to reach out to me with any questions or comments that were not answered in today's webinar or just about FQHC payment reform. Generally, we're happy to try and point you to the right resources or help answer your question. And then lastly, I just want to thank you all for joining today's webinar, and it's been a pleasure to work with the states in this academy, including Colorado, and I know I see a lot of other representatives from our academy states on the webinar too. And sincere thank you to Deanna and Shane for spending time with us today and sharing their progress. So as we close the webinar, you'll be redirected to a link to a SurveyMonkey page where you can respond to an evaluation of today's webinar. We would greatly appreciate if you take a couple of minutes and do that. Your feedback does guide our work. And with that, I will sign off, and thank you all for joining us today, and stay tuned to NASHP for more webinars and for more resources on this topic area. Thank you.